Guys, we are live on Instagram right now as we speak. All right, great. We got some people coming on Instagram now. Hey, everyone. We're going to have Tumor Talk starting in about 3 minutes. We're live on YouTube, on Instagram. We have a group of, actually a bunch of people. We have some folks from UT, Texas. We have folks from Rutgers as well. We're going to be talking about glioblastoma and also about laser-induced thermal therapy. So we'll start in a few minutes, all right?
Mm-hmm.
And Tony, how about you load up your slides so we can start right at 4? Exactly. So why don't we have everyone introduce themselves, say hi to our Instagram crew, all of our followers on Lenox Neurosurgery, about 25,000 people. Also, our YouTube followers as well on both the Journal of Neuro-Oncology YouTube channel and the Lenox Neurosurgery YouTube channel. I'm Nitesh. I've been one of the panelists on Tumor Talk for several weeks now, working with Dr. D'Amico. Randy is actually in the operating room right now. He'll probably be joining us shortly. We also have Dr. Sheehan also joining us in a little bit. But we have a large group. We have some good quality studies and award winners this week. So why don't we have everyone introduce themselves? Grant, do you want to start?
Yes, thank you. My name is Grant Arzman. I'm one of the PGY5 neurosurgery residents at Rutgers. Nitesh is actually my chief resident. Thank you for having us here.
Great. Antonio, Joshua.
Hi, how are you, everyone? My name is Joshua Eskenazi. I'm an assistant professor at UT Houston in neurosurgery. And some of the work that's going to be presenting Antonio, who's working with us as a postdoc and who will be applying to neurosurgery residency this coming March.
Hello, my name is Antonio Dono from UT Health. I work, as Dr. Eskenazi mentioned, as a postdoctoral research fellow, and I will be presenting our work here. Thank you for having us.
Awesome. Omar?
Hi, everyone. My name is Omar. I'm one of the fourth-year medical students at Rutgers Robert Wood Johnson Medical School, and I'll be presenting on LIT in the posterior fossa.
That's awesome. So we'll start off with Dr. Dono. Dr. Sheehan also just joined us. Hey, Dr. Sheehan, how are you?
I'm well. Thanks for presenting today. We hope you'll present for a little while and then have a few minutes of discussions. We try to keep this to about a half an hour conversation to keep everyone on their toes and attentive and still engaged. So thank you.
Awesome. Dr. Dono, please, floor is yours.
Thank you. Good afternoon, Dr. Sheehan, colleagues. Today I'm going to present our project entitled Molecular Characteristics and Clinical Features of Multifocal Glioblastoma. Glioblastoma usually occurs as a solitary lesion, but about 0.5 to 35% can present as multiple lesions. Based on radiographic features, multifocal glioblastoma can be further divided into multifocal glioblastoma per se and multicentric GBM. Multifocal GBM have a clear contiguity pathway of spread between foci, as you can observe here in panel B, when there is a T2 flare. Meanwhile, multicentric GBM are widely separated lesions that cannot be attributed to contiguous pathway, as we can see here in the T2 flare in panel E. The prognosis of multifocal GBM historically has been reported to be more dismal than single foci GBM, but mechanisms of multifocality and multicentricity are unknown. However, there are some small studies that have characterized multifocal GBM, and they have encountered that multifocal GBM lacks IDH1 mutation, ATRX, and PDFRA, but these studies were quite small. The goal of our study was to identify molecular characteristics and clinical features between multifocal and single foci GBM. We perform a retrospective review of our institutional cohort, and we define multifocal or multicentric GBM when they were separated for more than 1 centimeter between the foci. Multifocal and multicentric GBM were analyzed together, and we also performed an individual analysis in a sub-analysis. Next generation sequencing was performed in all the tumors that we're going to present by a 315 gene panel and 28 rearrangement. Additionally, co-occurrence of mutation was compared to TCGA and published studies. Importantly, GBM IDH wild type were cataloged according to the third C impact now criteria. As we can see here in the right figure, we started our institutional cohort with 564 infiltrating gliomas, and we have at the end 33 multifocal infiltrative gliomas that accomplished that met the criteria. And we compared the GBM IDH wild type within these 33 patients against 193 single foci GBM IDH wild type. To start with the results, here we observed a multifocal GBM oncoplot in which out of the 33 patients, 31 were GBM IDH wild type. And there were 2 patients that were considered GBM IDH mutant and a diffuse astrocytoma IDH mutant. Overall, multifocal glioma and multifocal GBM IDH wild type resembles the genetic landscape of single foci GBM with third promoter mutations, CDKN2AB loss, EGFR alterations, and PTEN and TP53 mutations as the most common alterations overall. We then evaluated the clinical difference between multifocal and single foci GBM, and overall there were no demographic differences between these 2 cohorts. However, we observed that multifocal GBM patients were less treated with GTR and NTR, as we can observe here, with single foci had a 35% and 18% of gross total resection, near total resection, compared to multifocal GBM in a 13 and 3% respectively. Additionally, in our institution, the multifocal GBM were more commonly treated upfront with irinotecan, that was statistically significant, and bevacizumab, even though this was not significant. Genetically, multifocal GBM and single foci GBM are very similar. However, multifocal GBM has a more frequently EGFR mutations than single foci GBM. Additionally, concomitant EGFR and PTEN alterations are more common in multifocal GBM, with a 36% compared to 19% in our single foci GBM cohort, as well as compared to the TCGA database of GBM IDH wild type. We then evaluated the survival difference by multifocality, and we compared the multifocal GBM IDH wild type cohort against the single foci GBM IDH wild type cohort, where we did not identify a significant difference survival. We also evaluated within the multifocal GBM cohort by multifocal and multicentric. Even though we did not identify any significant difference, there was a trend against in order to worse survival with multicentric GBM. We then evaluated the survival of the multifocal GBM cohort by the genetic alterations of it. And we observed that KDR mutant, aka vascular endothelial growth factor receptor 2, patients had a worse survival compared to the wild-type counterparts. Even though the sample was small, this was true after adjustment for multiple non-confounders as age, KPS, chemoradiotherapy, salvage bevacizumab, and multifocality. this was not observed in other mutations like EGFR, to put an example in the right panel, or any other mutation evaluated. To finalize, we review the known literature about multifocal GBM, evaluating around 15 studies. And importantly, we have the largest genetically characterized multifocal GBM with 33 patients, and the largest prior this study was 18 patients. Very remarkable studies that report decreased survival in multifocal GBM have a low resection or increased treatment with biopsy and a low percentage of chemoradiotherapy. As we can observe in our study, the percentage of biopsy was very low with 12%, and the percentage of chemoradiotherapy, according to a Stu protocol, was very high, 90%. This may account for the lack of difference in survival observed in our study, which also resembles a study by Hassan and al. From MD Anderson, which they did not have any difference in survival, and they achieved gross tumor resection in all cases. To conclude, the genetic makeup of multifocal GBM largely resembles single fossa GBM. However, multifocal GBM have a higher frequency of EGFR alterations and co-occurrence of EGFR and PTEN alterations. These alterations may account for their highly malignant and invasive phenotype. We all know that GBM is a molecularly very heterogeneous group, and a better understanding of the molecular features of GBM, including multifocal GBM, might help identify tailored treatments for different GBM subtypes. Additionally, aggressive treatment, as increased reflection rate and chemoradiotherapy, may improve survival in multifocal GBM, as has been seen in single fossa GBM. I would like to thank all my co-authors, as this paper has been recently published in the Journal of Neuro-Oncology, my two mentors, Dr. Joshua Skenazy and Dr. Leomar Ballester, to my lab members, and for all of you for your attendance and the opportunity to talk in this tumor talk. I will be happy to address any question. Thank you.
Dr. Jones, that was a beautiful talk and a great summary of your study. I feel that these multifocal cases are obviously, logically more challenging than single focus, just from a surgical standpoint. And as you said, it seemed like the oncoplot for the most part was very similar, but there was the difference in EGFR. Now, and they tend to be more aggressive. How can we turn this into an advantage based on your study's findings? How can we leverage more, chemo radiotherapy options for this disease?
So
what do you think the implications are?
There are two main points. As we observed in prior studies, most patients were just treated with biopsy, or a large percentage of patients were treated with biopsy, and they were not given the opportunity of chemoradiotherapy, and they go to palliative care. So as we observe, is there is no significant difference. Maybe our group is small, but the opportunity for these patients to do better with higher extent of resection, subtotal resection in the case that two craniotomies are not done, or the chemoradiotherapy, the standard of care, will improve the survival of these patients. Additionally, as we observe, there are certain mutations that are more commonly, and in this modern era of molecular diagnosis, it's important to understand better the tumors. So we might develop in the future as a community, neuro-oncology community, target treatments for these tumors.
I think just to complement on what Antonio said, that as we learn more about the genomic alterations of gliomas, we know that they're very different kinds. And we learn about midline tumors, thalamic gliomas that have H3K27 mutations, potentially multifocal gliomas, and as we see EGFR, and if you think about it, most of the trials have traditionally excluded patients that only get biopsies, which compromise a large portion of multifocal tumors, or tumors that are not resected or even multifocal. So we're really not sure about which are the therapies that could potentially be effective in this setting, either in the upfront setting or during recurrence. So I think this could potentially help us target treatments for gliomas, which nowadays have been characterized molecularly.
And so I commend you both on this outstanding study, and important in so many ways. And there's been a lot of work on EGFR mutant tyrosine kinase inhibitors for lung cancer, for instance. And I wonder if your work doesn't point in the direction of a personalized or at least a more targeted approach to these patients with multifocal GBMs, and looking at the mutation, specifically EGFR, as a means of a targeted approach to these patients that may not work as well in the standard GBM, just because the mutational differences or frequencies of mutations are so different, as you've shown.
Absolutely, yeah. As we know, EGFR inhibitors have remarkably worked well in lung cancer, and unfortunately did not work in all comers of glioblastoma, but certainly could they potentially be beneficial in this population, and that's something that should definitely be addressed and something that we're interested in.
And I mean, something that's intriguing too, I think, is this extent of resection in these multifocal patients. It does certainly raise complexities in terms of how to accomplish that, but we have better and better approaches now, as you know, as a neurosurgeon, to be able to do smaller, more image-guided approaches and resections and use of. We've had some other webinars that have focused upon technologies that are giving us endoscopic and port-based approaches to doing more deeper seated resections. And I think you pointed to the value of that potentially in these patient population, or this patient population as well. So wonderful.
Thank you so much for
and I think it's amazing when you show, I don't know if you can show that last, the second to last slide, I think, that where you review the literature, but really you looked at almost a 13-year period. And going back to maybe 2007, did I see that correctly? Go one or two slides above that. There you go. And so basically you've encapsulated the literature here from 2007 to current. Your study being incredibly important because of the molecular profiling, but you're still talking about just a couple hundred patients that are in the literature. Amazing work and speaks to the challenges of doing subsequent studies and maybe even a registry-based approach for these kinds of patients. But fantastic.
That's really great study, and thank you guys for presenting. So I guess we can move on to the next presentation since we're about 15 minutes in, if that's okay. We have Omar Ashraf, who's a fourth-year medical student here at Rutgers, who's going to present some of his work that he did with Dr. Arzumanov, who's also a resident here at Rutgers. So Omar, you can go to presenter view.
Here, one sec. Good, can you see that? Okay, great. All right, so I'm going to be presenting on LIT in the posterior fossa. Over the past decade, LIT has seen quite a bit of success, both in the treatment of epilepsy and in the field of neuro-oncology. Patients and clinicians love it alike. It has a minimally invasive approach. Patients stay in the hospital typically a day. But again, I think over the past couple of years, there's sort of been this transition from asking the question if something can be ablated to whether it should be ablated. And I think that's illustrated quite well in the posterior fossa. So the objectives, I'm going to talk about the efficacy of thermal ablation for tumors located in the posterior fossa, specifically looking at local control. And then I'll talk a bit about the complications that followed LIT in the posterior fossa for tumors. And then I'll try to go briefly through some some interesting trajectories that we've been able to implement for posterior fossa tumors. So background, I'm sure many of you are familiar with this technology. Essentially, it allows the stereotactic insertion of a laser into a specific focus of the brain, and then using thermal energy, you can actually ablate that region of the brain. And sort of shown on the right is you can use MR thermometry, which allows you to real-time estimate the amount of damage. So you can actually see the laser trajectory, and then the orange is actually the thermal damage estimate that you're getting in real time. So in neuro-oncology, it's used for primary brain tumors, radiation necrosis, recurrent metastasis. And in terms of LIT in the posterior fossa, it hasn't been reported on that much. I think the largest series is from the MD Anderson group in Texas, with 13 patients looking at radiation necrosis, as well as recurrent metastasis. So we really wanted to add our experience to the literature. And to that end, we report the largest series of data of patients that underwent LIT for posterior fossa tumors. So this was multi-center, as the title alluded to, and we did this in collaboration with the University of Miami, Emory University, Henry Ford Hospital, as well as our own data from Rutgers University. And we reviewed patients that underwent LIT for posterior fossa tumors over the past decade. So endpoints included local control as well as complications. In terms of local control, we defined as lack of progression. Progression, our study specifically, was enhanced that increased by a size of 25% in 2 dimensions over 2 consecutive scans, typically 4 to 12 weeks apart. And typically there's 2 major systems people use, either the NeuroBlate system or the Visualase system. All of the cases in this study were done using the Visualase thermal therapy system. So in terms of results, we had 58 patients or 60 tumors that underwent lit for posterior fossa neoplasms. Mean age was 56.4 years old, 18 male, 40 female. And in terms of location, we had 7 brainstem tumors, 52 cerebellar tumors, and 1 pineal region tumor. And the majority of patients did have some kind of prior intervention before lit, either resection, radiotherapy, or a combination of both. So in terms of pathology, there were 15 primary tumors and 45 secondary tumors. In terms of the primary tumors, there's quite a variety of different primary tumor pathologies you can see there. In terms of secondary tumors, there is something I want to point out. So typically our own institution, when we have a patient who presents with progression following stereotactic radiosurgery for a metastatic tumor, of course, the first 2 things we think of are radiation necrosis or recurrent metastasis. In our institution, we typically group them into one entity, which we call in-field recurrence. And we sort of do this because we feel lit is an effective approach for both kinds of pathology. And in that way, we can often sort of bypass the sometimes expensive and often inconclusive results that a workup would end up with. And then there was 1 untreated metastatic tumor as well. So a total of 45 secondary tumors. So in terms of operative parameters, this shows things like the preoperative tumor volume, laser power, ablation time for all of our patients. And then it's also broken down by different locations. The one thing I do want to point out with this is a little bit of a busy chart, but I want to sort of point your attention to the last line there, looking at the 24-hour post-ablation to pre-ablation tumor volume ratio. And essentially what this is a surrogate to measure the extent of ablation. And over the past couple of years, there have been some studies coming out looking at extent of ablation and its effect on progression-free survival. Specifically, 2 of the co-authors on this study, actually, Evan Luther and Dr. Komatar from Miami, have published on this in the past. And so we thought that'd be a cool little thing to implement in this study as well, to see if it had any relationship between either complications or local control. And so in terms of local control, we had a total of 48 patients that were available for follow-up. And over a median time of 9.5 months, local control was about 84%. For primary tumors, this was 60%, and secondary tumors, it was 90%. And when we look at in-field recurrence, it was 89.7%. And sort of alluding to what I said before, sort of the extent of ablation. Extent of ablation for patients with recurrence was lower than those without recurrence, but the difference was not statistically significant. So there's really not much we can draw from that. In terms of complications, of course, when we talk about posterior fossa, we want to look at complications. And in this case, we did have a total of 14 complications. 2 were procedural. They involved catheter misplacement as well as superficial incisional hemorrhage. Both of those patients did well postoperatively and didn't have any lasting effects from that. And then 12 patients out of the 50 or 58 did have some kind of new or worsening neurological deficits following lit. And the important part about this is looking at location. So 4 of the 7 patients with brainstem tumors had some kind of neurological deficit postoperatively, and 8 in 50 patients with cerebellar tumors had some kind of neurological deficit post-ablation. And the interesting thing is that I sort of pointed out how patients with brainstem tumors had lower extent of ablation, and we sort of do that intentionally as a way to sort of limit collateral damage to surrounding neural tissue. But as we can see, looking at the rate of complication in these patients, there's still a very high rate of complication. And the important thing to remember is that with lit, oftentimes you still can get thermal injury or post-ablation edema leading to postoperative neurological deficits. And of course, in looking at improvement, 5 patients showed partial resolution, or 4 patients with partial resolution, 5 had persistent deficits, and 2 had complete resolution at follow-up. And there was 1 mortality, and this was a patient with a 6.2 cubic centimeter glioblastoma in the midbrain. And postoperatively, he never woke up. And it was, looking at the imaging, we sort of think that it was because of very severe refractory edema postoperatively for the reason. So I just want to go over some interesting trajectories that we've been able to implement in the posterior fossa. So this was a 51-year-old male who had a history of a pineal region tumor, status for resection, who came in with balance difficulties. And sort of, institutionally, we use like a frameless stereotactic approach. And we feel like that's given us sort of the flexibility to implement more robust trajectories. So in this case, the important part with LIT is that you want to get the axis of the trajectory along the long axis of the tumor to really get maximal ablation. And in this case, the approach that we felt would do that the best would be a very inferior approach. And we feel like using a frameless approach it sort of allowed us to implement that versus more frame-based approaches to sort of limit your flexibility in your targeting. And this was a 69-year-old male who had a history of melanoma with a metastatic pontine tumor, status was radiosurgery, who then presented with left lower extremity weakness. And on the preoperative imaging in A, we actually see it's a right-sided anterior pontine lesion. In this case, we were able to do a transfrontal trajectory through the level of the midbrain. But again, like I said before, it all depends on the specific morphology of the tumor. And C and D is actually shown a different tumor in a different patient with a very similar location. And while in the first patient, we went transfrontal, in the second patient, we felt a transcerebellar approach would have been more appropriate to cover the entire tumor. And this was actually a case of Dr. Willie's from Emory University. So this was a 58-year-old patient with a history of breast cancer who came in with new onset gait instability and falls. A and B sort of demonstrate the lesion itself. It's a cerebellar vermean lesion. And then C and D sort of show a very interesting trajectory. And so in terms of planning this, trajectory, we felt that going transoccipital transtentorial would have given us best coverage of the tumor. And in D, you can actually see the catheter, the laser catheter, traversing the tentorium to reach the tumor. And then E is immediately postoperative, and then F and G sort of so 6 weeks postoperative. So in conclusion, LIT is an effective procedure specifically for secondary neoplasms. One limitation in the study was that we did have 15 primary tumors, but again, there was a very wide variety of primary tumor pathology, which sort of limits the conclusions we can draw from that sample. Again, though, this is posterior fossa, and it sort of alludes to what I said before. It's not really whether we can ablate these tumors, but whether we should. And a lot of these patients do end up with, post-operative deficits. 9 out of the 58 patients do have some form of post-ablation deficits at last follow-up, which is significant. So really what it comes down to is making sure, it's like any other neurosurgical procedure, you want to make sure that you have proper patient selection. Like in our case, that patient who had the midbrain glioblastoma probably wasn't a good case to do LIT. And as we sort of, publish more on this and sort of parse out which patients are more appropriate for, brain similar cerebellum LIT, we'll sort of have a better idea of how to approach these different tumors. Thank you.
Thank you, Omar. That was a great talk. My question, for you, and sort of being at Rutgers, I kind of know the answer, but definitely for our listeners, and perhaps Grant may be a bit more equipped since he's done more of these procedures, maybe you have as a medical student. With these long trajectories, obviously, your accuracy and your stereotactic registration are absolutely critical. I mean, you need sub-millimeter precision. So, there's frame-based approaches. There's obviously tracer-based approaches as well with different navigation companies. What approach do you guys, utilize here for these deep-seated lesions, or these lesions that are deep in the cerebellum where you need a high degree of accuracy, plus you're prone, so it makes using anatomic landmarks challenging?
So from what, and Grant, please jump in if I'm misspeaking, but from what I understand, we use skull pins. Actually there was a case where we had a patient with a posterior fossa lesion. And initially we were using scalp fiducials, but like you said, the anatomic landmarks sort of change your stereotactic registration. So we felt that using skull pins and using the Medtronic Vertec arm along with the precision aiming device has given us both flexibility as well as accuracy in targeting some of these deep-seated lesions.
That's exactly correct. Like Omar said, essentially our process is we usually get an MRI the day before when the patient arrives. And then in the OR, we place the skull pins and get stealth CT. And then we merge the images. And then we use the frameless with the Vertex arm and the Visual Ace system. And generally the results are pretty good, even for the long trajectories.
That's great.
And I'm impressed with some of the trajectories you've been able to accomplish, and with the safety and tumor, the infield tumor control that you've been able to achieve. It's been impressive. So great work, and I think that this points to just the versatility of lit in all locations, not just supratentorial.
Agreed. There's still, obviously lit is an excellent tool, but there's still a lot of work to be done. You know, we're still trying to determine, for us, one of the weaknesses in our study, we lumped together the posterior fossa, including the brainstem and the cerebellum. Looking forward, we probably should separate and look at studies at the brainstem specifically. Given the higher density of white matter tracts, we found that there might be more severe edema, even with lower ablation volumes. And a lot of these patients did have postoperative deficits. Now, we're still learning the limitations of the system. So over the next coming years, we'll probably better delineate patient selection, as Omar has said, but overall, it's a very useful tool for neurosurgeons.
No, it's absolutely true. I mean, I'll think back, and you know, I'm still a resident in my 7th year now, and when I was applying for residency, Omar, when I was in your shoes, you know, I had a few lit papers back then, and there were a lot of sort of doubts into its efficacy and its place in neurosurgery. And here we are, almost a decade later, where I think it's grown quite a bit in the armamentarium of neurosurgery. And it's not the answer for everything. I think we've learned a lot. But I think you guys did a great presentation. Thank you so much for presenting. Both of the groups did a really nice job. Thank you. Dr. Sheehan, do you want to close off with anything? Yeah.
Can I ask
please,
a question, Grant? Congratulations for your experience. I saw that trajectory, and obviously going through the tentorium is something that carries a risk, because obviously there can be some veins in there and bridging veins from the cerebellum. And I see that most of your trajectories are aimed at going into the long trajectory of the lesion, which is very reasonable. But the other option may be just to do 2 probes with a less risky trajectory, and then just in that form able to cover the majority of the lesion without taking the risk of doing those more aggressive trajectories.
That's a very good point, and we have done that before. We actually just this past week with Dr. Donish, we did 2 lasers for a lesion, especially lesions are lobulated. That's certainly something to consider. That approach wasn't done at our institution, but clearly they're very successful. Obviously, looking at the MRIs very closely and vascular studies if needed to make sure you're not traversing any vessels. And obviously the risks are involved. Even in this series that we're publishing, we did have a complication where a patient developed a hematoma as a result of the trajectory and required evacuation afterwards.
Well, outstanding work to both groups. Thank you so much for presenting. We do try to keep these on the 30-minute time point. I see we're just about at that. So I appreciate the presentations, outstanding, and thanks. We will send out more updates on the weeks to come, and hope you'll join us as members of the audience, and then also maybe in a future session as speakers again. Thank you.
Thank you for having us.
Thank you for the
so
invitation.
much. Thank you.
Thanks, everyone. Take care.
Thank you. Bye-bye.